The lost world gained again. In this case series, all the patients had a clear vision after successful phacoemulsification surgery. Few years after they complained of a gradual onset of diminution of vision, on examination they were found to have an opacified IOL. The only option for them to regain the vision of a lost world is IOL exchange. History of cataract surgery just 4 years back. A 2.8 mm clear corneal incision was made. Foldable IOL intimately adhere to a capsular bag. Difficulties to remove the IOL from the capsular bag. Due to capsular phimosis, careful separation of IOL from the capsular bag was attempted, but failed attempts to separate the optic from the phimosed anterior capsule with a cystitome or by manual sharp chopper manipulation prompted me to incise the anterior capsule with a sharp knife, that is side port. A repeated attempt was failed. Here the sharp knife is used to cut the capsule. Lift the IOL optic from the capsular bag. Both the haptics are cut from the optic and kept in situ to prevent the bag dialysis. Ultimately, the bag is opened in sharp knife or side port. Try to lift the optic from the bag with minimum manipulation and cut the haptic and kept in situ to prevent the bag dialysis. Traditional IOL unfolder is cut above and below for molding of IOL during explantation. Guitar string was used to mate the snare loop, which was passed through the unfolder, that is the trap. Drawing inspiration from common wildlife videos to catch the trapped cougar, that is the most dangerous animal, catch easily. A pre-sterilized fine guitar string was used as a snare to expand the opacified IOL through the 2.8 mm incision. The optic is centered into the trapped loop. With gentle pull, foldable IOL mold and pass through the unfolder. After that, triamcinolone acetonide was injected to detect any vitreous thread in anterior chamber, and also the vitrectomy done to remove the vitreous thread. A new foldable IOL exchanged, replaced and inserted into the sulcus. The IOL is placed into the sulcus gently and carefully. Try to rotate the IOL over the sulcus and center it. Anterior vitrectomy was done to remove the fine vitreous from the AC. In case 2, here is the approach somewhat different. It's a temporal approach because the haptics were vertically placed and both the haptics were cut from accessible different angle with minimum manipulation. Again, the snare is made by guitar wire. I will strap into the loop. Here the material of the I-well was so rigid, while pulling the snare it was transected into 2 hubs. Probably there is a biochemical changes due to long-standing staying in an anterior chamber. Its loses is molding property of a foldable I-well. A new foldable I-well again placed into the sulcus very gently and carefully. So here is entry and exit is the same route without modifying the own architecture, that is 2.8 mm incision length. This is the new methods and the devices applied here. In our series, all the patient get excellent vision with minimum change of preoperative refractive error. The astigmatism is a minimum and not much of change of astigmatism. This is the 3rd postoperative day of the right eye, and this is the 3rd postoperative day of the left eye. So the patient gained vision, the lost world gained again. Thanks to AIO for making this video and present in front of you. Thanks.